Hello. Um, my name is Shirley Cardinal. I'm an RN care manager for Dr. Grimshaw. I work for him 2 days a week. Next slide. So we're in Birch Run, and it's a rural community. Epic is our EMR. So it's Dr. Grimshaw, and we have a PA, Megan Dennings, and then myself for 2 days. We have four MAs. We've had staffing issues ourselves, and we just recently got our fourth permanent staff, and we've had a lot of temporaries. We are employed with Covenant Medical Group or primary care partners. On-site lab, we do not have one. We do on-site urine collections. Our patient population, we have about 2,240 patients, and with the Epic, I was able to run the high risk, low risk, medium risk. Our high risk population out of that 2,240, it's about 170. Medium is about 290, and then the low is almost 1,550. So we're able to, I pull reports on those risks too. So go ahead and next slide. So the advantages of Covenant's Epic is it's robust. It does so much for us. We are able to pull reports from our dashboard, ensuring that we are aligning to our HEDIS guidelines. So we have several built-in tools within Epic. We've got registries. The registry, as soon as you are diagnosed with diabetes or pre-diabetes, your name or a code goes into that registry. With that registry, I'm able to see your last appointment, when's your next appointment, what's your risk score, and really honestly, what your A1C was. So that registry helps me immensely pull reports. Like we don't have I can look at that registry and pick out who needs an A1C. Um, Care gaps monitoring, same thing. The care gaps, we have a thing that we call what's it called? Dashboard, or it's the like a snapshot, and it's on the side, and it's everything is in red. So if you have a care gap, it's in red, and it tells you need an A1C, you need a physical, you need a colonoscopy. So our MAs, when they're prepping charts, that's exactly what they're looking at, and they're pulling all their information into the chart prep for the doctor, setting up the orders for the uACR, A1C, anything that they need. Lets them know if they have to have a colonoscopy, if they've had their mammogram. And then we have a patient advisory set up on Epic that our physician or whoever's in the chart for that appointment, they cannot close out until that's been addressed. And then the smart sets are like our dot phrases. Our MAs are essential with their smart phrases and prepping the chart, and they have their own little setup and their verbiage that they use to prep the chart. So Epic has given us so many tools, and especially me as the care manager, I have so many places that I can look at data. Next slide. So with ours, we have 106 attributed patients and a 91.51% rate. Next slide. So the UACR screening success, it's consistent proactive patient engagement. What we do with that is beginning of the year, and of course our dashboard resets at the end of this year. So everybody's got a brand new slate. We are front desk MAs before the appointment. Either the back or the front desk will have called them and said, we see you don't have your lab. We need you to get your labs before you come in. Um, Consistent proactive patient engagement is exactly what we're doing. Constantly reaching out to patients to let them know that they need their labs drawn. If they can't come in and get their labs drawn, or they haven't been able to urinate when they get the lab, we do the draw right there in our office. Um, Next slide, please. So this is my Epic dashboard. It's a snapshot of what I see. So I can sort based on the eye exam, whether or not they're in the 8% or 9% A1C control, their kidney health evaluation, if we've had eye exams. So I can sort through all of this. And then as we enter the data, we're able to see the percent go up. So this is all based on our HEDIS measures. Um, Also, I use this for possible care management referrals. I can look at risk scores on this dashboard, see who's a high risk, low risk, medium risk. So I get a lot of my referrals just from this. I also use a collaboratively with the MCT2D dashboard. That dashboard tells us a lot of information, of course, but between the two, I get a lot of my own referrals right from there. Next slide.
Oh, went too far. Go ahead.
So I also use the PDCM report. Now, this PDCM report is from Blue Cross Blue Shield. This comes out oh, every 2 months or so, and it's got data that's old. It's about 3 months old. And this is based on claims. So at the end of the report, you can see that the categories, the BN, is their CKD clinical risk. So you can see that it's at risk and there's a moderate risk. Um, I can look at this real quick when this report comes out and see if there's anybody new that I haven't addressed. I don't know all of our patients, but I like to try to find them, the most of them, if I can. So I do use this report. Now, the next one is BN, the severity. This report tells me if they're high, moderate, based on their claims from Blue Cross Blue Shield. The next one is the BT, which is their severity of illness. It tells me if there's been any change since the last report. And then the BU is anything additional. Now, I also use this report to do my advanced care planning um, or, discussions with patients. I can look at this report to see if they've actually got advanced care planning. Um, this also ensures the appointments are made with the PCP and that we've got the appropriate labs. So it's a report I don't use often, but I do every time we get a report, I look at this information. Next. So we do nephrology referrals. We like to, take advantage of our nephrologist. Dr. Grimshaw will send a referral to Dr. Zaharik. She's a nephrologist. We also refer often to the kidney and hypertension consultants in Saginaw. Or if a patient already has someone in mind that they want to use as a nephrologist, we refer to nephrology if a GFR drops below 30 or if there's a rapid fall in GFR, he will send to a nephrologist. Go ahead, next. So our process for success has been, start of the year push. You begin ordering the uACRs, the A1Cs, the labs for our diabetic patient, first appointment of the year. They never leave without another appointment scheduled. Very important that you have that next appointment scheduled. The front staff, they check the labs for the appointment, like I said earlier, notify the nurses and care managers if it's incomplete. I peruse the schedule beforehand, usually the day before. Um, I already know if I'm going to get a referral from doctor prior to me getting a referral usually. Um, like I said, I'm only there 2 days a week. So I reinforce with the team reminders, calls ahead for appointments. If I notice when I'm calling a patient ahead of time, I'll look to make sure there's labs in there. There usually are, but there has been times where, especially when we've had staffing issues, where maybe a lab did not get ordered, and I'll facilitate that getting in. We do the in-office collection. So if we notice that we don't have the uACR, we will get that lab done there. And then the Epic Population Health Dashboard, that has been so big for us getting our testing done and compare against our schedule. Next slide. So tracking and data use, of course, I use the Epic Population Health Dashboard and the MCT2D dashboard. If you're not on that, I highly recommend that you get out there on the dashboard. Lots of great information. Um, I check upcoming appointments again against the dashboard, PDCM, serious illness, and CKD slots. Um, we use the reports for physicals, A1Cs, the annual checklist, like I said, mammogram, colonoscopy, and then the proactive referrals to our nephrologists if we need. Next slide. So the team role and coordination, our front desk staff, they do check in, check out. All four of these staffs are doing referrals, um, prior authorizations, patient assistance, um, you name everything that they're doing in the office. Plus, they're also doing these pre-visit lab checks and reminder calls. If a patient cancels, they can cancel their appointment on Epic, and we get notified that it's been canceled. They're making a phone call quickly to get them rescheduled. So we don't, our MAs are what we call our nurses. We do a lot of in-office collection, our patient education. Care manager, I do the dashboard monitoring. I also see a lot of our diabetic patients, so I will also talk to them about the importance and what the uACR means. Our manager, she pulls reports. She's coordinating with the front desk and the team to get gaps in cares done. We're doing a lot of that right now, pulling reports, making sure that we have the physicals and colonoscopies and eye exams. And then we have a wonderful community health resource partner with Epic who takes care of our SDOHs. So that's one thing that's off my plate, and that he takes care of the SDOH and then gets a hold of me on whatever else there could be, or maybe some needs that I have to deal with. Next. And so our challenges have been staffing. We have non-compliance with labs. We try to call them and bug them actually to get in there and get it done. After a while, they know they just have to do it. We have a lot of patients that are not using Covenant Lab, they're using the Quest. And so we have to make sure that we ask that question ahead of time and that they have the orders in hand. We also send them out to them before, call them, make sure they have the orders, and then we send them out to them. So that's a little duplication of work, but we're getting the urine done. Transportation difficulties, that is huge. We just recently had a patient, he's not a compliant diabetic. He uses Medicaid transportation, um, has a lot of barriers and issues. And the transportation stood him up at a 4:30 appointment. So then our staff is trying to find him, calling family, doing whatever we can to make sure he gets transportation home back to Saginaw from Birch Run. And then the lack of on-site lab services, but we also use the external labs however we need. But collecting urine on site has been for the uACR has been very implemental for our health, for our clinic. Next, I think that's it.
Really, thank you
I
so
talked really
much.
fast and I'm sorry, but thank you.
I just think across these three practices, I have a whole page full of pearls that I'm taking away, and I just really appreciate that. Heidi, I'm going to ask you, is there anything in the chat, and maybe we'll pick three questions and then move on. Do you see anything that's particularly
There
pertinent?
wasn't a lot of things have been answered, and I think it was more about like measures. I guess I would like to give the opportunity if anybody wants to ask our speakers any questions, they can certainly unmute and ask.
And
So
while
I'll
you're doing that,
pause.
I just have a question, and this is for anyone. When in the year do you start like, patients have a year to get their uACR. Like, how do you make sure you're not getting ahead of when they have an appointment and deciding who to reach out to?
And Lauren, this is your 7:28 time notice that you asked for.
So for us, it's a rolling year, right? So with our flow sheet, we know that it was in April, so it'll be due in April. So if they're there in February, we'll give them a lab order for April, and then if they show up for their March or their May appointment and it hasn't been done, we might grab the urine, might grab them in right there in the office. So we kind of, because the flow sheet tracks when it was done last, that's how we know. I did get an interesting, a direct question that was, how do you get the level of staff engagement you get? And I will say that we directly incentivize our staff, because as we earn pay for performance money in my practice, that gets shared with the staff. So my philosophy on that and my former partners was always that, if we couldn't get this job done if the whole team wasn't pulling to do the work. And so we share in the incentives with our staff, and that's why they're all motivated to help us achieve these goals.
Dr. Kabir, if you want to unmute, anything else to add or other wisdom?
No, I lost the internet connection, so I couldn't hear the response. But I think your question was, when do we start doing it? So we start doing it January 1st, and then we just keep doing it the whole year.
All right, well, I think I'm going to move us along because I did get a warning that I asked for. Anyone who wants to use to make hearts or appreciations or claps, please do. Those are always fun to see float in the screen. And I'm going to move us along to our last few parts of our presentation. So there's a lot I want to disseminate from the best practices that we've heard about. I think particularly in my practice, thinking about home nursing, uACR non-completion is very likely an indication that this person has something else going on in their lives, and there may be ways that we can help them. I know Medicaid transportation will transport people to the office and the pharmacy. I think maybe also to a laboratory. Maybe there are some things I'm not thinking of. And so how can we support you? We're going to, continue to provide more and more support to you to make sure that we can make sure that 10 out of 10 of our patients are able to have their uACR testing done. But here's some specifics that we've already started working on. So just to reorient everyone, and I think another takeaway is that we are happy to do dashboard tutorials. And I'll take your question at the end if that was a question. And so as you're going onto the MCT2D dashboard, you're going to select the legacy patient dashboard and you're going to go to renal details. So just this is a little bit hard to find, orienting you to where the uACR information is. And then you're going to go to filters, and then you're going to go to the uACR, as you can see on the right. And so we'll provide this information to you, but making sure that you know how to find the information on the dashboard. And then again, we have already started by providing some information for patients, but also for staff and providers and physicians focused on uACR screening. You just heard about best practices. We are partnering with the National Kidney Foundation of Michigan. So if there are any practices here who are really struggling with just having the manpower to do QI and find out how to improve on this measure, we have the opportunity to have some of our practices have a quality improvement facilitator work with you. And so we'll reach out to you about that later. And then obviously we're going to continue to share your quality progress on this measure.